ultrasound. Sorry, I forgot to start the recording at the beginning. But in terms of the ultrasounds, you've got the dating scan, like I said, which is sort of 11 to 14 weeks. And that's checking the gestational age, if the pregnancy is viable, whether there are multiple pregnancies, and also looking at nuchal translucency for Down syndrome. We'll talk a bit more about that next. And then the anomaly scan is more looking at sort of structural abnormalities and the placental position. So trying to work out if there's placenta previa and looking for things like spina bifida, anencephaly, or any sort of other abnormalities. And it's important that it sort of happens before 24 weeks because discussions around terminations sort of happen before 24 weeks. Okay, so the first question, what does the combined test for Down syndrome consist of? And I won't read through all the answers. I'll let you do that, and then hopefully there's a poll up, and it doesn't matter if you don't know, just put in a guess. I'll give you a few 20 to 30 seconds to make a guess. Okay, so pretty much everyone got the right answer. So the three things you're looking at are the nuchal translucency, which you see on the scan, ultrasound, and then serum beta HCG and Papa A. And if you've got a thicker nuchal translucency, raised serum beta HCG, but it's a reduced Papa A. And Papa A stands for pregnancy-associated plasma protein A, and it's usually produced by the placental syntrophoblasts, and low levels have been shown to be associated with Down syndrome, but generally also just a predictive marker of placental issues during pregnancy. And the combined test is looking for Downs, Edwards, and Patau. And it's called combined because you're looking for three markers, but you're using some imaging and blood results. Okay, so like we said with Down syndrome screening, it can be picked up on sort of two main occasions. The first one is the combined test, which we just spoke about. And the second one is the triple or the quadruple test, which is done at 15 to 20 weeks, rather than the combined test, which is done at 11 to 14. And the triple or quadruple test looks for alpha-fetoprotein, unconjugated estriol, and serum beta HCG. And if it picks up that you have a high risk of Down syndrome, which is usually about a cutoff of 1 to 150, then you need further tests. And these tests don't give us a definitive answer. They just give a sort of high risk or low risk. And then from there, the women can decide, whether you want to go on and have more invasive tests. And that's sort of like an amniocentesis or chronic villus sampling. And the combined test is ideal, but if women have missed the first test, then they can should be offered the triple test. Okay, so there's two types of diagnostic testing for Down syndrome, and these are diagnostic, not just giving you a high or low risk. And worth sort of bearing in mind as a side note that they're sensitizing events. So if you have a rhesus negative woman, you would potentially give anti-D, and worth just looking over that. So there are two types. You've got chronic villus sampling, which happens 11 to 14 weeks, and amniocentesis, which happens after 15 weeks. And it's really good OSCE station asking you to explain the different types of testing. So it's quite good to be familiar with the two different types and able to explain the sort of pros and cons of both. And so chronic villus sampling is you take some placental tissue with a needle through the abdominal wall, or you can do it through the cervix. And there's a risk of infection, and miscarriage rate is 2%. Whereas with amniocentesis, you're removing some of the amniotic fluid with a needle through the abdomen. And the risks of clubfoot or miscarriage rate is 1%. So the miscarriage rate with amniocentesis is slightly lower. And you usually get preliminary results in 48 hours, but full results within 2 weeks. Okay, and they might talk about an NIPT, which is a blood test that you can do from the mum, but it's not done on the NHS routinely, but sometimes people get it done privately. Okay, so hypertension in pregnancy is the most sort of common complication of pregnancy. So next question, a 28-year-old patient who was 23 weeks pregnant attends your GP concerned as she's worried about high blood pressure reading she measured at home. You take her blood pressure at the clinic, which is 162 over 114. She has no symptoms, no past medical history, no evidence of proteinuria on dipstick testing. What's the best course of action? Okay, poll should be up now. Okay, great. So I think most people put the right answer. So the answer is you want to do an urgent obstetric assessment. So anyone with a blood pressure over 160, over 110 are likely to be admitted and definitely need to be urgently assessed at the hospital. It's not really appropriate to give blood pressure monitoring for 7 days. This doesn't really happen in pregnancy. And repeating it tomorrow would just delay treatment. So with the blood pressure over 160, you definitely want to refer straight to the hospital. So in terms of hypertension in pregnancy, there's sort of 3 main sort of discrete types. And it's good to know sort of what would distinguish between the different types of hypertension. So you can have someone who has pre-existing hypertension. So blood pressure of 140, less than 20 weeks. And if it's pre-existing, it happens sort of before 20 weeks. And in terms of management, you would primarily give labetalol, which contraindicated in asthma, or nifedipine, or you can give methyl-dopa. But this is when you'd introduce 75 milligrams of aspirin from 12 weeks. So pregnancy-induced hypertension is then when you get new onset hypertension greater than 20 weeks. And it resolves after birth, usually, and sometimes known as gestational hypertension. And you would refer all of these patients to secondary care and admit any with a blood pressure over 160. So then preeclampsia is the one that we really worry about, and that's pregnancy-induced hypertension with proteinuria. So if you have a blood pressure over 140 after 20 weeks and you've got proteinuria greater than 0.3 grams, but usually just found on a dipstick. So anytime they mention protein in the urine, you're referring patients to secondary care. And the only sort of definitive management of preeclampsia is delivery. So in terms of preeclampsia, the main symptoms are headache, visual disturbance, nausea and vomiting, sometimes edema, so asking about any swelling around the face, hands, feet. And if you have a patient with right upper quadrant pain or hyperreflexia or reduced urine output, it's usually severe preeclampsia and you should be really quite worried. So complications are HELLP syndrome, which is good to look up and be aware of, or eclampsia, which is when the patient will start having a seizure. And it's good to know the management of that in terms of an A to E station. So for management, you'd admit these patients and try to lower their blood pressure. So you can give oral or IV labetalol, oral nifedipine, or oral hydralazine. And if you've got severe preeclampsia, you would probably want to be giving IV magnesium sulfate, 4 milligrams. And also can consider corticosteroids if you're thinking of delivering early. So IM dexamethasone if you're under 34 weeks and you'd want to fluid restrict the mother. And other things to consider are also sort of fetal investigation. So you need a CTG and you want to do bloods, so FBCs, knees, LFTs. And if it's severe, they need to be monitored 3 times a week. So very close monitoring. Okay, any questions about that so far? Feel free just to speak up. Okay, so moving on to diabetes in pregnancy. So I'll let you read this question while I get the poll up. So a 28-year-old pregnant lady with a fasting glucose of 7 millimoles and a 2-hour glucose of 8.1 millimoles. Okay. Yeah, so well done. Again, pretty much all of you got the right answer. So if your fasting glucose is above 7, this is first line. So dietary advice is appropriate if your fasting glucose is less than 7, but as soon as it's above 7, you need to be giving insulin. And you wouldn't give gliclazide because you stop oral hypoglycemics in pregnancy. And same with liraglutide, and metformin would be second line after insulin. Okay, so gestational diabetes is considered a pre-diabetic state, and it's defined as fasting glucose greater than 5.6 or a 2-hour glucose greater than 7.8. And those are just 2 numbers that you need to know. So risk factors are high BMI, greater than 30, ethnicity, previous history of gestational diabetes or a macrosomic baby, which is more than 4.5 kilograms, and a first-degree relative with diabetes. So in terms of screening, if there's any history of gestational diabetes, then you want to do an oral glucose tolerance test at the booking and at 24 to 48 weeks. And if there are any other risk factors, then you just need to do it at 24 to 28 weeks. So the main complications that you worry about with gestational diabetes are, there's some for the mum, some for the fetus. So for the mother, hypertension, preeclampsia, and sort of trauma with birth, because you can end up with a macrosomic baby, which can cause lots of complications at birth. And again, for the fetus, that's mostly macrosomia shoulder dystocia. So gestational diabetes is a real risk factor for shoulder dystocia, and also premature birth and RDS. So in terms of management, if you have a new diagnosis, then there's a joint diabetes and antenatal clinic in 1 week. and you want to educate patient about self-monitoring, diet, exercise, and also just if the fasting blood glucose less than 7, you're giving metformin and insulin, or you can, if it's greater than 7, then you have to be giving insulin. Okay, we're actually going to keep going. So in terms of placental pathology, here is question number 4. Okay, so we've got a 29-year-old, 29-week gestation coming in with painless vaginal bleeding. She's hemodynamically stable. What's the most appropriate first-line investigation? Okay, just give you a few more seconds to put answer in. Okay, so a bit more mixed, this one. So the right answer is transvaginal ultrasound. And that's because it's the gold standard to localize the placental position. And what you're worried about here is placenta previa. So because you've got painless vaginal bleeding, that's quite key. And your first line investigation for that would be transvaginal ultrasound. So an abdominal ultrasound is usually appropriate, but she's a bit early. And usually it would have picked up a low-lying placenta, but with a patient presenting like this, she might not have had her fetal anomaly scan. And if you have vaginal bleeding, you do not perform a vaginal exam until the placental position is confirmed, because it can cause massive bleeding in placenta previa. Again, things like fetal CTG and bloods are important, but they won't help confirm the diagnosis. So when you get antepartum bleeding, the main thing you're trying to determine is it, if it's to do with the placenta, is it placenta previa or placental abruption? And placental abruption is when the placenta sort of separates from the uterine wall. It's really painful. You can get vaginal bleeding, but often you get this sort of shock that's not proportionate to the amount of blood, because some of the blood can sort of stay concealed, like between where the placenta's detached. So risk factors are increased maternal age, smoking or cocaine use, preeclampsia or trauma. And on examination, you get this like tender woody uterus is how they usually describe it. It's really painful. And like I said, you've got this sort of hemodynamic instability that's sort of disproportionate to the amount of blood. Whereas with placenta previa, you have a low-lying placenta, so it sort of covers the cervix, and you get painless vaginal bleeding. So that's sort of like the main distinction. And risk factors for that are multiparity, multiple pregnancy, like twins, if there's any history of previa or C-section or any kind of uterine abnormality. And the important thing is you're not doing a vaginal exam, but you want to do a transvaginal ultrasound. And for both of them, CTG particularly important for abruption because you tend to have quite early fetal compromise. Okay, so here are just some pictures showing placenta previa and abruption. So you can see in abruption, you've got the placenta coming away from the wall and the blood kind of pooling behind it. Whereas with placenta previa, it's covering the cervix. And you can have different grades of placenta previa. So it can be fully covering the cervix, partially covering it, or just a tiny bit. And But the important thing is just to know that you've got a low-lying placenta and placenta previa. So in terms of management, for a placental abruption, you're wanting to do regular observations, bloods, you want to do an FBC, use knees. Important to do a coagulation and cross-match, and also group and save, because there's a very good chance that they might need a transfusion if they've got such hemodynamic instability. You want to do an ultrasound to exclude placenta previa and, like we said, fetal CTG. So in terms of management, you are definitely admitting them and doing an A/E assessment. So can be an A/E assessment station in OSCE. And if you've got a fetal heart rate present, then it depends whether or not they're in distress. So if they're in distress, you want to do an urgent C-section. No distress, less than 36 weeks, you're monitoring. No distress, more than 36 weeks, induced vaginal delivery. Obviously, you as a medical student or junior doctor wouldn't be making these decisions. You'd be escalated to a senior, but just to know that what happens. And if the fetal heart rate is absent, you want to induce vaginal delivery. So then for placenta previa, a transvaginal ultrasound is gold standard. And you want to admit with an A/E assessment as well. And they might need an emergency C-section if you can't stabilize them, or if they're at term or in labor. And, oh, sorry, I need to go forward. And if it's picked up in the 20-week scan, then you can rescan at 34 weeks. And if it's still present, then you do 2 weekly scans and you do a final scan at 36 to 37 weeks. And that's just because as the baby grows and the uterus expands, sometimes if a placenta is just covering part of the cervix, it can move. So that's why they rescan. And again, considering anti-rhesus D if you've got a rhesus negative mother and steroids of less than 34 weeks. So just a quick note on vasa previa. So vasa previa is when you don't have the placenta covering the cervix, but you have the sort of fetal blood vessels in the umbilical cord covering the cervical os. And you can get the fetus pressing on it and causing vaginal bleeding. So the sort of classic triad of vasa previa is you get rupture of membranes, painless vaginal bleeding, and fetal bradycardia. And it's managed with an urgent C-section because obviously the blood supply is directly from the vessels to the fetus. So compromise is pretty quick. So just important to be aware of vasa previa as well if you've got painless bleeding. Okay, and I think Hassan's going to take over now. Are there any questions on the first half or anything you wanted to ask?
Are we good to go?
Yep, I think so. And just there'll be a QR code at the end. If you can just scan that and fill out any feedback, that'd be really helpful and appreciated. Thank you.
Right, yes. I'm Hassan. I'm also a final year. I'm here to just sort of pick up on the obstetrics lecture. We're going to pick up from issues in pregnancy. Shall I share my screen or are we keeping it on yours?
Yeah, I was just about to say, probably easier if I stop sharing.
Yep. Right. And everyone see that?
Yeah, I can.
You'll see the slides change.
Yeah.
So a 20-year-old pregnant lady has come in at 11 weeks gestation, complaining of excess nausea and vomiting. She says that she's not been able to eat much in the last week. What can be used to assess the severity of her symptoms? So for this one, if we can just put it in the chat, what people think, we can discuss it afterwards. Got one person saying 4. Any other takers? Right, good. Right, so 2 viewers said 4. I think I said enough. Yeah, so the correct answer is 4. Basically, this lady is presenting effectively with morning sickness. And she's not been able to eat much. She's vomiting. She's 11 weeks gestation. It's all pretty much within the necessary time frame that we're looking at. The other options are kind of hinting towards things that could, lead towards morning sickness. So getting a serum beta ACG. It's all that morning sickness and hyperemesis gravidarum is pretty much due to elevated levels of beta ACG. The risks of which include things like trophoblastic pregnancies or multiple pregnancies, so having twins, also obesity as well. And creatinuria levels are pretty much just noting it, assessing the kidney function in a state where you're excessively vomiting. So if you're worried about things like dehydration, consequential AKI, those are what those answers are alluring to. And it's not just a clinical diagnosis on its own. In terms of assessing the severity of the symptoms, you'll use the pregnancy unique quantification of emesis, which is what the question is asking. So in terms of which is conveniently called puke score, the puke score, the index is divided into less than 6 for mild, 7 to 12 for moderate, and more than or equal to 13 for severe. And the management of how you manage each of these varies depending on the quantification of how severe the vomiting is. So if it's only mild, then you can advise generally these mothers to just uptake their fluid intake as much as they can, ensure they have small regular meals. Sometimes ginger is used as an adjunct, a kind of sort of herbal medicine or remedy. And if they identify any triggers that triggers the nausea, I aim to avoid it. If we're talking about moderate, where we're thinking about patients who are still struggling despite conservative management, you can include medication like promethazine or cyclizine, even metoclopramide. But can I just ask, first of all, anyone in the chat, they can say out loud, if you're giving a patient metoclopramide, what are you worried about? Does anyone know? Good. Yeah, extrapyramidal side effects. So in general, when you're using the antiemetic metoclopramide, I believe it's a D2 antagonist. And being a D2 antagonist, you run the risk of causing extrapyramidal side effects. So things like tardive dyskinesia, Parkinsonism, pilogyrate crisis, these can all fall under the category of using metoclopramide. And if any patient presents with dehydration, they even if they're moderate, they are still managed in secondary care regardless of whether they scored 7 to 12 or more than 13. Okay. So hyperemesis gravidarum is a step above morning sickness because there's a sort of subtle nuance that needs to be appreciated. They're not exactly the same. So it's extreme nausea and vomiting less than 20 weeks gestation. And it's not a joke because if you're vomiting so much to the point where you can't get fluids or food down, you are putting yourself in an incredibly vulnerable state, especially when you're carrying a child as well. So the associations with it are basically states where it's thought that there's more kind of HCG floating around, so multiple pregnancies, trophoblastic disease, nulliparity, so first-time pregnancy goers are more at risk of hyperemesis gravidarum, obesity, and also hypothyroidism as well. But hyperemesis gravidarum is actually a triad. And this triad falls under the category of needing 5% pre-pregnancy weight loss. They need to have some evidence of dehydration, and they need to have a corresponding electrolyte imbalance as well from the excessive vomiting. So you'll categorize the severity with the puke scoring system. And in terms of when you want to think about admitting to hospital, so we spoke about referral to secondary care with regards to dehydration, but reasons to admit kind of follow on from excessive vomiting. So if the patient is absolutely unable to keep any fluids or antiemetics down, then you want to admit them into hospital. Because then we need to think about potentially using IM and IV preparations of antiemetics to really subdue the nausea. If a patient has a suspected comorbidity or confirmed comorbidity that already puts them at a greater vulnerability of potential complications, such as things like UTIs or diabetes, they also need to be admitted to hospital. And if there's identification of ketonuria and weight loss despite treatment with antiemetics, then you need to admit to hospital as well. And again, like we said, there's a low threshold for those with comorbidities with regards to admitting them to hospital because their situation can escalate very out of control quite quickly. And the management, as we said, split into conservative and medical. So avoiding triggers for conservative, small frequent meals, and ginger if needed. In terms of medical, typically we're thinking about antiemetics like promethazine and cyclizine, but also as well, that in some instances, second line you can use metoclopramide, but we're worried about extrapyramidal side effects. I think particularly if we're moving past 5 days of using it as well. In terms of additional things to consider, so hyperemesis gravidarum, because you're in a dehydrated state, you're running an increased VTE risk. So you may want to think about VTE prophylaxis, especially if someone is admitted into hospital. So whether that's in the form of TED stockings or even low molecular weight heparin. And in addition to that, one of the potential offshoots of hyperemesis gravidarum can be it can precipitate wernicke's. So you need to think about as well in terms of prescribing things like Pabrinex and folic acid as well, just to ensure that we don't run into these complications. IV fluids as well, in terms of if someone's severely dehydrated, that may be required. And if you guys just remember quickly from fourth year, what conditions can follow excessive vomiting? Excessive and intense vomiting. If I just ask for the chat to respond. Is there anyone that could name one? Yeah, good, exactly. So, things like Mario-Weiss tears or Borhoff syndrome, they're also on the table if someone is vomiting aggressively frequently. So it can spiral out of control in that fraction as well. You also have to note, though, in terms of what you're looking at, this is an acute abdomen case as well. So you want to also assess for any other cases of acute abdomen, whether it be things like appendicitis, hepatitis, pancreatitis, or peptic ulcers, amongst other things. You need to sort of make sure that your differentials are open to that. Yeah. So, 24-year-old woman who's 35 weeks pregnant is diagnosed with UTI secondary to group B streptococcus. She's treated with oral antibiotics. How should this woman be managed during labor? Cool. So we've got two answers in the chat. Both of them are 3 and both of them are correct. Why are they correct? Because in this instance, basically looking at a woman who she's group B streptococcus positive. And GBS positive mothers at any point during the pregnancy, they qualify for IV benzyl penicillin during labor. And this effectively acts as a prophylaxis because group B streptococcus is a major risk factor for neonatal sepsis. So basically when the baby is born, if they develop sepsis, it is most likely that it tends to be caused by GBS, I think especially within something like 72 hours. So in terms of nothing else needs to be done, it's not appropriate. C-section at term doesn't actually deal with the potential infection risk. The neonate antibiotics, we need to give these antibiotics prophylactically, so we're not giving it once the neonate is born. And swabs and cultures, we don't need to do as they've already been done. And in terms of GBS in pregnancy, the most common organism is Streptococcus agalactiae, and it's the most common cause of neonatal infection. So the risk factors that are helpful to keep in mind, especially when thinking about needing to give someone intrapartum antibiotics, are if any woman presents with a GBS in their current pregnancy, if they have a history of GBS in a previous pregnancy or a history of neonatal sepsis in a previous pregnancy, if they're in preterm labor or they have premature rupture of membranes, or if they spike a fever during labor or while the child is in them, then you would be thinking about giving them intrapartum antibiotics as a prophylactic measure. The diagnosis typically just requires a vaginal swab. However, there is no universal screening. A lot of it is done, I think, based on risk and the previous history of the mother about whether they want to test you for GBS and evaluate your risk there. And then the swab as well is done at 35 to 37 weeks or before about 5 weeks before the anticipated delivery date. And the antibiotics that are typically used are intrapartum IV benzyl penicillin, but also, as you guys always have to remember, at this point, what you want to get yourself in the habit of doing is just mentioning that you need to go after local hospitals' guidelines, because in the future you will be checking the hospital's micro guide to verify which antibiotics that hospital uses for given infections. And in terms of puerperal sepsis, so just as how in non-pregnant individuals you have the NEWS score, in pregnant individuals, in pregnant women, you'll have the modified early obstetric warning score, which is basically their form of, it's a scoring system that will show you whether a pregnant woman is deteriorating or not. And in this case, puerperal sepsis is defined as any temperature over 38 within 14 days, so 2 weeks of a pregnancy. The most common cause of puerperal sepsis would be endometritis. And endometritis is effectively an inflammation or irritation lining of the uterus. And endometritis can occur because, for example, you may have retained products of conception. And if you've retained products of conception, that products, they can be infected, they can froze, and I think you can use a transvaginal ultrasound to identify them. And these, it's why it's important as well in the third stage of labor that when the placenta is delivered, all the products of conception from the placenta are checked to have been removed and accounted for. So doing things like counting the lobes of the placenta to make sure that you have all the lobes, making sure that the correct number of vessels are within the umbilical cord. These are all checked when a placenta is removed following labor, just to make sure that there's nothing remaining in the uterus that can result in endometritis. And the antibiotics here, you'd admit any woman with puerperal sepsis. Here they say IV gentamicin, clindamycin. Again, you want to check your local guidelines. But other potential causes of puerperal sepsis also include things like a UTI. It could be a wound infection, especially if a woman has undergone a cesarean. So the scar could have been infected. If she's had any perineal tears, and also even mastitis. If there's an excessive buildup of milk in the breast that eventually becomes infected and becomes a lactational abscess, that can cause sepsis in its own way as well. So a 36-year-old multiparous lady, G5P4, with a BMI of 31 has come to her first antenatal appointment. You discuss her lifestyle changes and discover she's also a smoker. You decide to perform a VTE risk assessment and decide on appropriate treatment. Based on her risk factors, which treatment pathway would be used? Any options in the chat? We've got two twos, which those are the correct answers. So, in terms of managing VTE in pregnancy, in this instance, you would be looking for the VTE risk factors, those risk factors being an elevated BMI of 30, they're a smoker, multiparous, the age, and in pregnancy, warfarin is contraindicated. You can't use warfarin in pregnancy. So if you are going to use a blood thinning medication, you're going to use low molecular weight heparin. And you continue all this anticoagulation until 6 weeks postpartum. So it begins antenatally and it continues to 6 weeks postpartum. And it's a prophylactic measure to prevent any VTE, to reduce any VTE risk. And in itself, pregnancy is also a huge risk factor for VTE by default. It's already a prothrombotic state, but there are plenty of other risk factors to look out that also exacerbate the risk of VTE in pregnancy. So BMI over 30, increased maternal age, so over 35 years old, multiparous women over 3, smoking, a current preeclampsia, a family history of VTE, any thrombophilias that a patient may already had, and multi-pregnancy as well with regards to having twins or triplets. And in terms of how you want to manage it, if there are more than 4 risk factors that you can identify, then you want to get a woman started on low molecular weight antenatally. And as I said before, you want to continue it until 6 weeks postpartum. But if we're talking about under 4 risk factors, then you can start low molecular weight heparin from 28 weeks until 6 weeks postpartum. Okay. And it's important to note as well that DOACs and warfarin are contraindicated in pregnancy, but warfarin can be used in breastfeeding. It's a little distinction there that just needs to be remembered because it is important for you guys to know which medications are allowed in breastfeeding and which aren't. So warfarin is allowed in breastfeeding, but it's contraindicated in pregnancy. And the extra things to note as well is that if any woman comes to the antenatal booking and they've had a history of VTE, and then they need referral to secondary care ASAP, so care under an obstetrician, and they'll also need low molecular weight heparin, I think, from the get-go. Intermediate risks, so for example, if they're being hospitalized, having surgery, then they'll need antenatal prophylactic low molecular weight heparin as well. And in any DVT diagnosis made before delivery, you have to continue the anticoagulation treatment for at least 3 months. And this is basically the same measure you'll take towards any provoked VTE, basically. So remember, provoked VTE, you want to anticoagulate for 3 months. Unprovoked VTEs or unknown cause, or cancer, you want to anticoagulate for 6 months. Okay. A 28-year-old pregnant woman comes to the GP complaining of yellow and itchy skin for 2 weeks. She's currently at 30 weeks gestation. She's had no complications so far. On observation and examination, there's visible jaundice in the sclera, and you notice scoriation marks throughout her abdomen, but otherwise nothing else. Bloods reveal slightly deranged LFTs with a significant rise in bile salts. What is the diagnosis? Any takers? Okay, just in the interest of time, I'll move it on. But the correct answer here would be obstetric cholestasis, so number 1. And the reason for that is that one of the most typical things of obstetric cholestasis is incredibly itchy hands and feet, with jaundice as well in pregnancy. And in terms of the other differentials that we could consider, HELLP syndrome is you would notice things like hemolysis and low platelets on the bloods. It wouldn't just be a deranged LFT, and in terms of slightly deranged, it would be a lot more deranged. In terms of viral hepatitis, Again, when we're thinking about the acute abdomen and anything affecting the liver, it is appropriate to include in the differential, but there's nothing in the stem to suggest it. Acute fatty liver pregnancy is very important. It's sudden sort of right upper quadrant pain, vomiting, low-grade fever. It's a very, very severe presentation. I don't think you would expect just slightly deranged LFTs. There would be a quite a wide range of systemic upset. And autoimmune hepatitis as well would probably incur a longer history. And again, things like fever, right upper quadrant pain. But here we're just looking at a case of obstetric cholestasis because we also have a cholestatic picture that's formed as well. So we're talking about women typically within the third trimester, and basically there's reduced bile flow from the liver, and this results in an increase in bile acids in circulation, which causes the itching. So it's the biliary tree is basically sort of being occluded and obscured, which kind of leads to a cholestatic picture, as I said. And that cholestatic picture will present with things like pruritus, which again, as I said, is particularly worse in the palms and the soles, but also jaundice. And you can also, I mean, it's more on the rare side, but other cholestatic pictures to look for would be things like dark urine and pale stools. Okay. And it's not as common as well, but you can get things like a bit of right upper quadrant pain. But the main things to look out for would be excessive pruritus and some jaundice, along with fatigue. In terms of how you'd manage the condition, any kind of buildup of bile salts, in this instance, to improve the itching, you'd always give ursodeoxycholic acid, and this improves the bile acid, sort of rising bile acid symptoms like the itching. And you can also use bile acid sequestrants like cholestyramine. In terms of the things that you'd want to consider for regards to delivery, you want to induce labor at about 37 to 38 weeks. And inducing labor is the definitive treatment for obstetric cholestasis. It will just get rid of it straight away. So inducing labor at 37, 38 weeks and just delivering the child is the definitive treatment. And in this instance as well, you may have to use vitamin K to reduce the risk of PPH. It's also important to note that obstetric cholestasis does increase the risk of stillbirth. So it does need to be caught. It does need to be managed appropriately because it increases the risk of stillbirth, which is obviously not what we want. Yeah. So moving on to labor. So labor just takes a bit of time to break it down into the different parts that are relevant to you, that you're going to be questioned on, and that you'll need to speak through them in OSCEs, because they could get you to explain the mechanisms of labor in an OSCE station, or talk through the different stages of labor, or they could get you to interpret a CTG. In this lecture, there is no CTG interpretation guide, but Geeky Medics is a really good one that will walk you through it quite well. But labor can effectively be divided into the physiological signs of labor and also signs of true labor. So in terms of the physiological signs, these tend to onset between about 37 and 42 weeks. And they tend to be things like a nesting instinct from the mother, heaviness in the legs and the back, and a spur of energy in the mother. In terms of signs of true labor, these tend to be things like the sort of 3 or 4 cardinal signs that we think of, which are basically painful rhythmic uterine contractions. And rhythmic is important because prior to labor, you can have Braxton Hicks contractions. And the things that differentiate them are the fact that they're irregular and they're not rhythmic and they're on and off. So it means it's not really a true labor. They're not really true contractions. They're just the uterus kind of prepping itself for labor. And I think typically mothers may just be asked to just keep their fluids up and just rest to wait for them to go away. But it's painful rhythmic contractions that are needed, dilation of the cervix, a show, which is basically a shedding of the mucus plug that sits within the cervical os. I think mothers will mention that there's mucus in their underwear, in terms of like that's how the show is passed. And then also a rupture of membranes as well, which is sort of the breaking of the waters. And in terms of dividing true labor into steps, there's 3 stages. And stage 1 is anything from 0 centimeters of cervical dilation to full 10 centimeter dilation with contractions. Stage 2 is from full dilation to expulsion of the baby. And then stage 3 is basically delivering the placenta. So separation of the placenta from the uterine wall, and then delivery of the placenta and membranes. So a 25-year-old pregnant lady comes in saying her waters are broken. She's currently at 35 weeks gestation. How would you manage it? Does anyone else want to add in? Got one answer in the chat.
Yeah, also 2.
Good. Okay, correct answer is 2. So, got a pregnant lady here. She says her waters are broken, and she's currently classed as a preterm rupture of membranes because she's at 35 weeks, and from 37 weeks onwards is ideally where we want labor to onset. So, in terms of how to manage her, we use steroids and antibiotics. The reason of which being that it's a preterm, pre-labor rupture of membranes. So, you basically, the minute the membranes rupture, unless the woman is in labor, what happens is that you run the risk of inviting infection in utero while the membranes are ruptured. So that can lead to things like chorioamnionitis and also maternal sepsis, and ultimately things like stillbirth and maternal death. So you immediately have to give antibiotics as a prophylaxis. And the antibiotics like erythromycin are typically water used in this instance. In terms of the steroids, because you're worried potentially about preterm labor following this preterm rupture of membranes, you need to give steroids because you want to avoid neonatal respiratory distress syndrome, and you want to make sure that the fetal lungs are developed enough that in the event that the baby is delivered on a preterm level, they don't end up having neonatal respiratory distress syndrome. And there's no indication to actually induce labor at this point. You think about inducing labor typically if there's maternal or child instability, but as long as the mother is stable, you try and stretch the pregnancy as long as you can out towards the 37-week mark. And she's not actually having any rhythmic contractions, so you don't need tocolysis, and no treatment required would be irresponsible. So rupture of membranes, there's a number of definitions that you need to be aware about. So there's spontaneous rupture of membranes, premature pre-labor rupture of membranes, which is more than 1 hour before labor. There's prolonged rupture of membranes, which is more than 24 hours before labor starts. So that's considered prolonged. So ideally, when you rupture your membranes, you'd like to begin labor within 1 day. There's preterm rupture of membranes, and this is basically where it occurs before 37 weeks. And then there's prolonged preterm pre-labor rupture of membranes, which is rupture of membranes for more than 18 hours in a preterm baby. Okay, the point is that there's that whole water breaking feeling, the sudden gust of fluid per vaginally, and the risk, the complications that you're worried about in this instance would be things like preterm labor and more worryingly chorioamnionitis. So, preterm prolonged rupture of membranes. This takes place before 37 weeks. And one of the risk factors for this tends to be things like bacterial infections. So any pregnant lady that has bacterial vaginosis is at increased risk of having a preterm prolonged rupture of membranes. In terms of the management, you would like to admit them, and you need regular obs because you're basically trying to monitor for any early warning signs of sepsis and chorioamnionitis. So things like elevated respiratory rate, tachycardia, hypotension, fever, all these things that really point towards chorioamnionitis. Steroids because you don't want infant respiratory distress syndrome, neonatal respiratory distress syndrome, and you'd want erythromycin to be given for 10 days And I think it's 4 times a day, 250 milligrams or something. But again, you would consult local hospital antibiotic guidelines. Yeah. And you can consider induction of labor. Again, it's probably quite variable. It's obviously this is quite senior led. But after 34 weeks, they may think about inducing labor if they're worried about the state of the mother or the state of the child. And yeah, in terms of rupture of membranes at term, the risk factors for these would be things like Braxton Hicks contractions and cervical ripening. These weaken the membranes. And how you would manage this is you would expectantly manage for 24 hours. Okay, because basically ideally you'd want the labor to start within 1 day. But if you cross the 24-hour mark, then you would think about trying to stimulate labor yourself, so augmentation. So you may stimulate with membrane sweeps, with oxytocin, prostaglandins, and then you'd also want to think about as well giving intrapartum benzyl penicillin. If they're penicillin allergic, things like clindamycin. Yeah, just as antibiotic prophylaxis. And in terms of if pervaginally any meconium stained liquor is passed, or there's pyrexia, or there's a previous swab of GBS, then you'd want to induce the labor very quickly and give intrapartum antibiotics just to get the child out basically of the mother, so that you can then manage. It's the safest course of action, because as a general rule of thumb, I remember being told by an obstetrician, dead mother equals dead baby. So in an instance where the mother is sort of where she's deteriorating, or there's evidence that it could deteriorate, it's important to get the child out quite quick. And in terms of infection risk, you don't want to do any vaginal examination if you think if there is a rupture of membranes, because of the risk of you introducing infection through the vaginal examination. So actually, in terms of the augmentation, I think you would just stimulate contractions with oxytocin. I don't think you would do anything like a membrane sweep or anything, because again, that would involve you inserting fingers and potentially introducing infection into that environment. So there's no vaginal examination whatsoever. But apparently you are allowed to use a speculum, and the speculum can be used just to assess for pooling of amniotic fluid within the vaginal vault, just to confirm that there's been a rupture of membranes. And you can also use an ultrasound if you don't find any pooling, to see for any oligohydramnios, just to ensure that there has been a rupture of membranes. I'm not entirely sure, but I would be safe in exams. And as a general rule of thumb, if there's been a rupture of membranes, you would avoid any procedure that involves vaginal examination, because it increases and introduces infection risk. Sure. So the augmentation will probably take place along the lines of just stimulating contractions with oxytocin. I don't think you do it. I don't think you do a membrane sweep, because I know a membrane sweep is used to induce labor, or at least assist it. But again, it would probably involve you having to insert fingers and introduce infection risk. In terms of preterm labor, so the definition of this would be any regular contractions, because remember we said regular contractions are what define labor. So regular contractions and cervical changes at less than 37 weeks, because from 37 weeks onwards is when the baby is classed as being at term. So, and the minimum class sort of viable pregnancy is usually at 20 weeks gestation. However, I have heard that there is some variability in this, very case by case, but generally it's 20-week gestation. The risk factors for preterm labor include things that have already been mentioned, like preeclampsia, which is an important one for you guys to remember, but also in general, increasing maternal age, history of alcohol or smoking, or even a multiple pregnancy, so having things like twins, that runs the risk as well with preterm labor, and infections as well. So UTIs and any STIs, amongst other things. And you would investigate preterm labor with things like high vaginal swab, especially if you're looking for things like infections and also STIs. And you would also assess the high vaginal swab for fetal fibronectin. And the fetal fibronectin helps determine the likelihood of a birth within 48 hours. And if there's a high NPV, and then therefore, if it's negative, it's unlikely for labor to occur within 2 weeks. But another thing that's important to remember is that when thinking about the risk of preterm labor occurring, you may, for example, if they're less than 34 weeks, you may need to consider using magnesium sulfate because this reduces the risk of cerebral palsy. And in terms of the management of preterm labor, you'd want to monitor, and most will stop generally spontaneously, but you still want to monitor for any potential complications. But if there is a history of prematurity and premature births with regards to the maternal history, then you can think about doing things like placing cervical stitches or cerclage, which acts prophylactically to prevent a preterm labor. And again, in terms of ensuring lung maturation of the child, you think about intramuscular steroids, I think dexamethasone. And if you want to stop the contractions, you can think about tocolysis. However, you do not stop the contractions if there is evidence of chorioamnionitis, because again, you want to get the baby out in that instance. So tocolysis is a contraindication to it. But current medications that are used for tocolysis are things like nifedipine, calcium channel blocker. And nifedipine is also the second line hypertensive management if labetalol is contraindicated in preeclampsia. And side effects to note will be things like dizziness and an increased heart rate. So, a 26-year-old lady has had a massive obstetric hemorrhage. It was found that this was due to uterine atony. What is the first line medical management, assuming an ATOE is performed and she was resuscitated accordingly? We've got one answer in the chat. Anyone else?
3 as well.
Yep, so 3 is the correct answer. So in terms of medical management, with uterine atony, it's the most common cause of postpartum hemorrhage. Initially, you think about doing things like catheterizing the patient, doing uterus rub, just to stimulate contractions to help reduce the atonic nature of the uterus. And afterwards, you can consider medical management. In this case, you'd be thinking about oxytocin being given first line. Nifedipine is a tocolytic, so it's going to do the opposite. It's going to stop the contractions, it's going to exacerbate the bleeding. Ergometrine is a later line of management, so is misoprostol. Ergometrine is contraindicated in hypertension, just as a note, it's very SPA-able. And atosiban, just like nifedipine, is also a tocolytic. So hemorrhages, you have to divide them both into either antepartum hemorrhages or postpartum hemorrhages. So antepartum hemorrhages is anywhere between 24 weeks and delivery. And the 3 major causes of antepartum hemorrhage that you guys should sort of always have at the front line of your mind be things like placental abruption, placenta previa, and vasa previa. In terms of how you want to admit these scenarios, how you want to manage these scenarios, you've got to admit the patient for observation, and you'd always carry out an ATOE assessment in these scenarios. As an acutely unwell patient, you need to do an ATOE because you need to resuscitate them accordingly. And in any case of hemorrhage, you want to get a full blood count, using these LFTs, coagulation screen, group and save, cross match. And if we're talking in the instance of Rus negative women, then you want to do a Kleihauer test just to make sure that you can give them anti-Rus D at the appropriate amount that they need if they've had any kind of antepartum hemorrhage. You can use an ultrasound to determine the cause, and in these scenarios as well, with regards to obstetric emergencies, you need to get yourself used to thinking in the case of two people as opposed to just one, because frequently I think a lot of us have been used to doing A2Es and assessments on just one person, and immediately in front of you, the only person you see in the scenario as well is just the mother. But you have to remember that there's the child as well, and the child also needs attention, they need monitoring. So always remember to get a fetal CTG. In terms of other things to consider, if you're worried about delivery being imminent, you can always give corticosteroids as well at less than 34 weeks, again, to prevent neonatal respiratory distress syndrome. And you always want to, once you've stabilized the patient, once you've resuscitated them accordingly, you need to get a senior midwife, an obstetrician, an anesthetist, and a porter. Captured in the acronym SOAP. In terms of postpartum hemorrhage, we're thinking of more than 500 ml of blood loss within 24 hours following delivery. And typically the causes are divided into the 4 T's. So you'll have tone, trauma, tissue, and thrombin. Tone is by far the most common one. The most common cause of postpartum hemorrhage will be uterine atony, but it can be due to trauma, so perineal tears. It can be due to tissue. So, for example, if there's still retained products of conception, the placenta is still in there, and thrombin as well with regards to any pre-existing coagulation disorders in the mother. Again, it's an A2E assessment. You want to resuscitate them accordingly. And for major bleeds, you need 2 liters of warmed fluids and potentially a blood transfusion. And you want to think about catheterizing the patient, because, as I said, with regards to uterine atony, if you catheterize a patient and empty the bladder, it puts less pressure on the uterus and it allows the uterus to contract more effectively. And in terms of, again, bloods you want, full blood count, using these LFTs, coagulation, group and save, and cross-match 4 to 6 units. And it's the same calling for SOAP after any of these hemorrhages. As I said, most commonly secondary to uterine atony, so you want to do uterine massage and a bimanual compression. Oxytocin, as you guys correctly mentioned, is first line. 5 units at stat immediately. And in terms of other agents which can be used to help uterine atony to simulate contractions, you can consider ergometrine. However, as I said, this one is contraindicated in hypertension. You can also consider carboprost. However, this one is contraindicated in women with a previous history of asthma. And in terms of adjuvants that can be given with oxytocin, tranexamic acid 1 gram IV is also useful because I think it's an antifibrinolytic and it helps stop the bleeding, basically. And the classification of the PPH as well, it's primary if it's within 24 hours of delivery. From 24 hours to 12 weeks, it's considered as a secondary PPH, which is just helpful to have in mind. And a minor, any PPH is over 500 mil, but a minor PPH is 500 to 1,000. Major is 1,000 to 2,000 mil, and major severe, so severe postpartum hemorrhage is over 2 liters of blood loss. And yeah, the Amnesty Year 5 OSCE pack has A2Es, obstetric A2Es for you guys to work through in your own time, just to get yourself in that rhythm of thinking about both the mother and the child in the scenarios and how to manage them both accordingly. In terms of maternal collapse, there are a number of causes that you want to be thinking about. So causes can always be divided into the 4 H's and the 4 T's. The 4 H's being hypovolemia, hypoxia, any electrolyte disturbances like hypo or hyperkalemia, and also hypothermia. But in the instance of a mother, you can have things like sometimes, for example, if a mother, if she's not laid down correctly, you can have think it's aortocarpal compression, which just reduces the amount of blood return to the heart, which can cause the mother to collapse. Which is why it's always ideal that mothers are they're encouraged to lie on their side, and also during I think CPR on a pregnant woman, one of the stages is you push the fetus to the side so that it doesn't compress the vena cava and the aorta as much. In terms of the other causes, the 4 T's, thromboembolism. So in the case of a pregnant woman as well, you have to consider things like amniotic fluid embolisms as well as pulmonary embolisms, but toxicity as well. So any medication that was administered that induced the collapse, tension pneumothorax. So again, trauma, reduced breath sounds on one side and deviation of the trachea to the contralateral side, and then tamponade as well, with Beck's triad, muffled heart sounds, raised JVP, and hypotension. And this is the sort of the resus. It is a potential OSCE station about trying to give CPR to a pregnant woman. And as I said as well, it's the same kind of scenario where we're talking about doing ABC, but you need to call the obstetric resuscitation screen team, and you need to wedge or tilt the patient into the left lateral position, because as I said, the fetus itself, when the mother is lying down, is pressing down on the aorta and the vena cava, so you need to have them wedged or tilted to take that pressure off. And then otherwise, you do CPR at a compression of 30 to 2, and you would consider getting a defibrillator and attaching it so that it can monitor for any signs of reversible, for any shockable rhythms, amongst other things. But you don't need to go too in depth to this in terms of like the shockable, non-shockable part. It's more just knowing the reversible causes, the 4 H's, the 4 T's, and also remembering about the moving the fetus to the left lateral position. So an amniotic fluid embolism, again, as I said, is something to be on your mind. It's very rare, but it is a potential complication of pregnancy. And it's kind of in the name. Amniotic fluid enters the mother's bloodstream, and what it does is it stimulates an immune reaction. And it has been known to occur after artificial rupture of membranes or labor or C-section, or directly after labor. And the symptoms are sort of similar to other embolus symptoms, so chest pain, shortness of breath. They can be, they can have chills or sort of low-grade fever, and collapse, as we said before, because it's one of the causes of collapse. Patients will be cyanotic. In the most severe cases, hypotensive and tachycardic, which basically builds a picture of circulatory failure. And again, you want to carry out an A to B, and you want to resuscitate accordingly to deal with the hypotension, the hypoxia, and these patients are typically managed in ITU, so they receive very, very supportive treatment. Oh, okay. So that concludes the tutorial. Does anyone have any questions or anything? I'd be happy to stay around for about 5 minutes to answer them.
Yeah. Do you know how we can access the slides and the recordings?
In terms of the slides and the recordings, I think you're gonna have to ask Zanel for that. I'm not quite sure myself.
What's their email?
Zanel, has he been sending messages to your group chat advertising this?
Let me take a look. Maybe I haven't checked.
Also, if it's all right, could you guys just scan this QR code? This is just a personal QR code from me.
Sure, yeah.
Cheers.
Is it? No, Kavindu's been sharing it on our group chat. Who's the person I should contact?
Zanel Kanami. I don't actually have his email, but
How do you spell his name?
Zenel.
Zanel Quinami.18 at ucl.ac.uk.
Yeah.
Yeah, thanks. I'll contact him.
If you can just scan both QR codes and fill in the feedback, that would be great. But otherwise, I'll linger around if anyone's got any questions or anything.